Hi everyone, thank you so much for coming today. I'm really excited to be doing this talk, and my goal really is that this is going to be very practical. That's what I'm hoping for. This is talking about frailty in the older person and handle with care. So at this point I have no conflicts of interest to disclose. And I wanted to dedicate my presentation today, in particular, to our team. And I want to dedicate it to nursing and to allied health, because really with the collaboration of my colleagues, I wouldn't be able to do the work that I do. And I'm always learning and being inspired by their advocacy and their knowledge and skill. And I think that frailty really lends itself to a team approach, the concept and the management, just as many geriatric issues do. So today's objectives are, what is frailty? Good question. Why does it matter? And how do I assess for it? So this isn't me, but we can imagine that it was me when I first was starting out. And when I was first in medical school, I actually had no idea about geriatrics. It's hard to believe. I was sitting in a mentor group, and I think I was second year medical student, feeling, well, I wasn't first year anymore, isn't that great? And one of the new first year medical students, we went around and said, so what do you want to do when you grow up? And he said, I want to be a geriatrician. And I'm like, what the heck is that? I hadn't heard of that. I really had no idea. So I said, well, what is that? He says, well, it's looking after older people. I said, and in my mind I was like, why would you want to do that? So clearly I've changed my tune since then. And I think a lot of it had to do with, first of all, meeting some amazing geriatricians, and also caring for patients. So I remember very clearly in my training when I was doing critical care, and I'm going to tell you a little bit of a story. So I was in the intensive care unit as a resident very early on in my training, and there was a gentleman who was in his 80s who had been admitted for an elective abdominal aortic aneurysm repair. And this gentleman had been in the ICU before I arrived on my rotation, and he remained in the ICU when I left my rotation. He had known dementia. He was blind, completely blind, and also profoundly deaf. He clearly had a prolonged period of delirium, and the intensivists and the nurses and the team there were really had no idea how to proceed. And when I saw this, I was asking myself, how can this be? How could this happen? How could a person in their 80s go for this extensive surgery when they have dementia, are legally blind, and deaf? I said, what were the people thinking? And I wasn't thinking that anyone had malicious intent. I think everyone was trying to do good and do the right thing. But I was like, I must be missing something because this doesn't make any sense to me. Now I look at this and I say, actually, I think I understand a little bit better about it. I still don't have a good feeling about it. I don't think it was right. But I think that that our system can easily fall into that trap. And we all, when we're thinking about ethics, we remember the principle of beneficence, so to do good. And so I do think, the physician, the surgeon, the family, all I think wanted to do good. They wanted to prevent a rupture of that abdominal aortic aneurysm, because that could happen. Then non-maleficence, that's harder to do, not to do any harm. And I think we all recognize that anything that we do or not do has some risk. And I think one of the things that why I really embrace the idea of frailty is because it helps me look at that risk and helps me to weigh the benefits and the risks of anything that is being considered for a particular person. So when I use Frailty, I'm able to advise patients and their loved ones. I'm able to look at the treatment that's offered, weigh the benefit and the risk, and get informed consent. Now, of course, we're supposed to do that for everybody, right? But how do we do that when we're looking at somebody who's frail? Now, typically, when we look at risk and we talk to people about it, what's often said is, you have a 1% chance of a heart attack, you have a 1% chance of stroke, and a 0.1% chance of death. Okay, so that sounds small, but we're not looking at things that often affect our older patient and are extremely important to them and to their loved ones. Other risks that are often not discussed or not recognized as risks are delirium. And we know that it's not just the simple delirium that when you fix the pneumonia, now they're going to be completely clear. We're talking about complicated, prolonged delirium that may result in permanent cognitive decline once it's cleared. Immobility, not being able to get out of bed, not being able to get around safely. Dependence, so not being able to manage their activities of daily living, requiring other people to help them with that. Prolonged hospital stay. Clearly, the gentleman that I talked to you about in the intensive care unit had a prolonged hospital stay that wasn't anticipated. And another huge one, unable to return home or unable to return to where they were living before the procedure was done or is considered. And these are extremely important factors that our patients and our families care about. And like I said, the risk that we usually talk about doesn't include these. For example, CHAD score doesn't look at that. So this is looking at the risk of stroke in atrial fibrillation. So looks at congestive heart failure, looks at hypertension, and I think the marker for frailty is just saying the age over 75, but that's not really the right way to look at it, I don't think. Diabetes and prior stroke, right? And here you go, the only one that's looking at perhaps frailty is age over 75. And the other thing is I was taught through my training is that age is an independent risk factor for many things. So it's independent risk factor for heart disease, stroke, cancer, dementia, and on and on. But I clearly saw in my training that age wasn't enough. To just say, oh, you're this age, and therefore we're either not going to do something or we are going to offer you something, or you're at risk for this or you're not at risk for that, I didn't think was enough. It didn't help me stratify my patients clearly enough to be able to give them good information. I mean, we've all seen this. He's a good 85. Well, she's an old 69. Her cells are old. So I've heard those things, and we all know it to be true. I certainly have read charts, and I read the chart, and I read the list of past medical history and what the person has been through, and I'm like, my goodness, what am I going to do with this person? And I meet them, and they're not like that at all. Yes, they've had all of this, but that doesn't necessarily mean they're a bad old. So we have to think about robust older people and frail older people. And this is a great slide, I think, for that. Here we've got someone on their bicycle. She's cycling, she's got good balance, she's got good exercise capacity. Then we've got another person there who looks like he likely doesn't have good balance as he's in a motorized chair and doesn't have good endurance. So this is the picture of frailty versus robust older person. So while advanced age does correlate with frailty, it doesn't equal frailty. So that's a big, I think, take-home message, is that we just can't lump everyone in by age. You might have also heard other people talking about other ways of thinking about this, and they're sort of synonyms for frailty. So you might hear physiologic age. I think that's a good synonym. So I think frailty actually is physiologic age versus the chronologic age, okay? You might have heard vulnerable elders. I think that's true, absolutely. I think that frail older people are vulnerable. And at-risk elders, I think that's also a good synonym. The idea of frailty was first introduced by Dr. Brocklehurst, who was a United Kingdom geriatrician. And he introduced that in 1982, and since that time, the concept has just taken off. If you take a look at the number of publications that have happened, and this only goes up to 2000 here, but it's really a huge sort of jump in publications since the time the concept was introduced. And part of the reason I think that's true is because it has good face validity. I think all of us can say, yes, that makes sense to me that some of the older people that I see are frail and vulnerable, and some of the people that I see are not. So they're like, this concept seems to make sense. The problem is that it's been hard to figure out, how do we actually measure it? How do we actually think about it? It becomes quite nebulous and not very concrete. So some of the predictors that we know for frailty are extreme age. So it's a predictor. It doesn't equal frailty, but it is a predictor. If someone has vision loss, if they have impaired cognition or mood, if they have any limb weakness, if they have an abnormal gait or balance, and if they're using sedatives. Also, multiple chronic diseases also are predictors of frailty. So Dr. Linda Fried came up with this definition. She studied cardiovascular health and aging in large population cohorts, and she described it this way. And I think that this is a good concept to sort of start in our understanding of frailty. A physiologic syndrome characterized by a decreased reserve and resistance to stressors. So something bad happens, the person doesn't have a lot left. And it results from a cumulative decline across multiple physiologic systems. So a decline in their cognition, a decline in their breathing, a decline in their spine, a decline in etc. Keep going. And it causes a vulnerability to adverse outcomes. And some of those adverse outcomes I referred to before: the delirium, functional decline, etc. And frailty, unfortunately, it can be a vicious cycle. So someone who's frail gets an acute illness, and if they don't have complete recovery, which is often the case, certainly when we have acute care medicine needing to move patients as quickly as possible, our vulnerable, frail, older patients are not able to have complete recovery. This is where places like the geriatric medicine unit and the geriatric rehabilitation unit are absolutely key, but we're not touching the whole population and the problem. And if people don't get full recovery, their frailty gets worse. So just to say that there is a sort of a physiologic underpinning or understanding of what frailty is. It's not just this concept. We actually think that it has a biological basis. There's actually mice that are considered frailty mice. And this one has interleukin 10 blocked. So it's a cytokine that is anti-inflammatory, and in this mouse, this one, the older looking mouse here, it's blocked. And these mice lose strength more quickly than the control. They also have increased apoptosis of skeletal muscle cells, so that means that they get more and more sarcopenic. So it looks like there's some connection between inflammation and frailty. So this is a really busy slide, but I think it's really very helpful if we go through it step by step. I'm not going to go through absolutely everything in this slide either. So if we start here with sarcopenia, so that's the loss of muscle mass. And that leads to, of course, decreased strength and power, and also affects our metabolism. Then our walking speed decreases. With a decrease in walking speed, we get increased disability and dependency. That tends to lead to chronic undernutrition. So people are not taking in enough calories, they're not taking in enough protein, and of course that is a vicious cycle, just as I showed you before, where we get increasing loss of muscle mass. Another key concept is the concept of homeostenosis. This is a great geriatric medicine concept. It certainly helped me a lot in my understanding when I'm caring for my patients. So we all know about homeostasis. So that's our body's ability to keep us at on an even keel. So our temperature stays relatively the same, our blood pressure stays relatively the same, our oxygen stats stay relatively the same. We have about the same number of red blood cells we did today as we did yesterday, unless of course we have an acute illness, but we try and keep things the same. That's what our body does. Stenosis, meaning narrowing, is so the ability to have that homeostatic reserve gets narrower and narrower with age and with increasing frailty. So here's the physiologic reserves along the y-axis, and on the x-axis is increasing age. So here, at a younger age, there's a stress here. It could be environmental, it could be an illness, it could be emotional, and so here you're requiring increased physiologic reserves. But you're not going over your limit, and you can easily restore yourself back to your baseline. As time goes on, however, that very same stress goes and puts you above your physiologic limit. When that happens, you get sick. So that's why a younger person can have a urinary tract infection, be uncomfortable, need to take antibiotics, but otherwise is fine. And an older person falls, is delirious, ends up in the emergency department, and has a prolonged stay in hospital. That's the difference. So some people have tried to think about frailty in other ways. So what if we counted how many diseases somebody had? Well, there is an overlap, so this is the big number here. There is a low overlap between somebody who has a lot of diseases and frailty. So there is an overlap there. But there are, as I told you before, many people that have many diseases who are not frail. So we have to really look at that. We have to be thoughtful about that. Again, other people are like, well, if they have a disability, then the person must be frail. Well, again, that's not true. While having a disability might increase your risk of being frail, as I said, vision impairment will do that, increase your risk. It doesn't necessarily mean that you are frail. There is an overlap. The other thing that I think is really important to know is that there are people who are frail, who do not have many diseases, and who do not have a disability. And those are people that we really need to pay attention to because we don't have those other markers that we're used to looking for. They're frail and they're very vulnerable. So what are some of the features of someone who's frail? Well, they very easily become sick. I can remember one time Dr. Barbara Power, I can remember saying to her when I was early on in my training, so what's one of the key things that you think you've learned in geriatric medicine, or what do you think is a kernel that we should take with us? And she said, older people get sick very, very quickly, and they get better very, very slowly. To me, that's just a cardinal feature of frailty right there. The other thing is frailty is progressive. There are ways to intervene, and we'll talk a little bit about that. But it is a progressive process, and at a certain point, there probably is a place of no return. And the other thing is that frailty is not an illness, and it is not a disability. So what's the prevalence? So certainly here in the hospital, we would think that the prevalence of frailty must be like 90%. But you know what? That's not true. For most of older people, they're not frail. There's certainly a portion that are pre-frail, and that's a key population that we need to address to try and prevent them from becoming frail. But it's only about 10 to 11% of the general older patient population that is frail. Certainly, they are frequent flyers in our hospital, in our emergency department, in our inpatient units. And so we have what was called a sampling bias. We see a lot of them. So frailty, here, I love this slide. I think it gives a lot of information in a nice, simple way. So here, if you look here on the y-axis, you have performance. So low performance going to high performance. And you can see graded areas. So there's disability, there's frailty, and then there's normal aging. And on the x-axis is time. So this person here in the red line is aging normally. And up on the top, they have full performance. At a certain point in their life, they start having some frailty. But it is not affecting them in such a way that it's causing them to have disability, and they die. For whatever reason, not sure. This other person here has accelerated aging, or so-called old cells. And here they are going along, and they get into this area right here where they're frail and don't have a lot of disability. And that's really the time for sure to act. That is the time where we can make a huge difference to reverse their frailty, as Dr. Dalziel likes to say, unfrail them. And I think that's a great thing to think about, that it's not a static situation. We can do something about it. And I think we all in this room have a big role to play in that. But the other thing is once you get out of that, you get into an area where we actually are not able to reverse frailty. And at that point, we have to be very, very careful about what we want to do to these patients. We have to think about those risks that I talked to you about. We have to think about delirium, cognitive decline, immobility, dependency, and not being able to go home. So there's been, just to let you know, so there's a lot of controversy about frailty. I'm telling you that I think it's great. And the reason I think it's great is because I think it helps me. Now, if somebody points out a reason why it's not good and why it doesn't help me, I'll say, okay, well, tell me something else. But just to let you know, there is a lot of controversy. And I've even heard people say things like it's the worst thing to ever happen to geriatrics. So while I'm here telling you I think it's good, just know there's a lot of controversy. So when you look at frailty screening and outcomes, so this was a study that looked at what do most of the tools that we're using to assess for frailty, what do they do, and what are the outcomes that they looked at. And the reason they did this is because there's a lot of tools out there to try and figure out how do we get to frailty, how do we know? So if you look here at what are the identifying factors, so the top ones were their physical function, their gait speed or their mobility, their cognition, their weight loss or their BMI, and their physical activity. Boy, no wonder I'm dedicating this to nursing and allied health, right? Then if you look at outcomes, the things that they looked at were death, disability, institutionalization, and hospitalization. There's other things as well, falls, physical performance, functional decline, and other, but those are the top ones that they looked at. So there's a few ways to look at frailty. One of them is rules-based, and an example of that is the frailty phenotype by Fried, and I'll show you that one. Another one is an index variable, and an example of that is from the Canadian Study in Health and Aging, and it has 70 items, and you count them up, and then you get a ratio of X over 70. And then there's clinical judgment. And that one is, an example of that one is the clinical frailty scale. So here's the phenotype that I was telling you about. So this has 5 variables, and you measure each of the variables, and then if somebody has 3 to 5 of them, they're frail. If they have 1 to 2, they're pre-frail, and if they have none, they're not. So that seems pretty good, right? Well, it gets a little bit more complicated. So weight loss, that's not too hard. We can ask someone if they've lost more than 10 pounds in the last year. Exhaustion, so you can ask them, felt that everything I did last week was an effort, could ask that. But then the slowness, so you have to time them for walking 15 feet, and you have to base it on a chart that looks at sex and height. So it makes it a little bit more complicated to apply clinically. Could do it, but not so easy. Low activity level, so you actually have to calculate their physical expenditure per day. So you have to kind of look at what they're doing, and so that's much more, that's more than I can do when I'm seeing a patient. I'm already spending a long time with people. Then weakness, the other thing is you measure their grip strength, so you have to use a hand dynamometer. So that's a special piece of equipment, not too complicated. But then you also have to apply a table where it looks at cutoffs based on sex and BMI. So while this is good and it shows us some very important factors that are present in frailty, it's not so easy to use clinically. Now here's the Frailty Index. Gotta love that one, right? I think we should just get everyone to pull that out and just count all those things for each of their patients. Yeah, right. This, I think, is a nightmare. It's used for research. Great for research, not very useful clinically. I definitely do not want to count up how many of 70 different items does a person have. So looking at the predictive validity of these different models of looking at frailty, so the rules-based one, we talked about the Fried phenotype of frailty, and then the Frailty Index was that 70 item one, that was an example, and then clinical judgment. So if you look at the hazard ratio, really, clinical judgment was pretty much as good as the Frailty Index, which was seen to be maybe slightly better, but not very practical. So how do we do clinical judgment? Well, anyone who has worked with me knows that I use this. I like it for a number of reasons. One of them is that it is sort of provides a gestalt of the picture that you're seeing of the patient. The other thing is I find it very helpful in sharing it with somebody's loved ones. They are able to look at it, and often they're able to say, oh, I think they're here. And often they're right. And it also helps me discuss the concept of frailty with them and tell them about how their loved one has increased vulnerability. I know this is a very small slide. We're going to go into this in more detail. The other thing is frailty and prognosis. So I've told you that there's adverse outcomes. And here, this is based on the clinical frailty score, so that's that same clinical judgment. And it looks at the top one here is the probability of survival, and the bottom one is avoidance of institutionalization. And the highest scores are 1 to 3. And so here you can see there's separation quite early on in terms of time, and people that have low scores survive longer. And about institutionalization, we have basically the same kind of pattern. So the increasing scores, increasing risk of institutionalization. Increasing scores, increasing risk of death. So frailty does predict clinically relevant outcomes, and it is independent of disability and, it shows incident disability and death rates. And its predictive value is independent of comorbidity, so that multiple morbidity. It's independent of disability and other disease-specific indices. So, assessing it. If we look at, so the clinical judgment that I was talking about basically has 4 components, and I'm going to break it down for you. And the main reason I'm doing that is to just show how our allied health team and nurses can have a big role to play in this, and that it's not that hard, okay? And just to sort of give you maybe a little bit of way of sort of operationalizing how we do this. So there are 4 components to the clinical frailty scale. They include mobility, social, function, and cognition. So if we just start off with mobility, and we start from 1 to 2, so these people are thriving or they're well. So these are the fit older person. This is a fit older person. They exercise regularly, and I rarely see them. Normal aging, they are active and they do some occasional exercise. If they're vulnerable, they're starting to slow down. They're often tired. Mild, walking slower, and they are starting to need gait aids. Then if we look at moderate, they need help to go up and down stairs, or if they're on uneven ground, they're needing help to get in and out of the bath, or if they've fallen more than once in the past 6 months, excluding a slip on ice. If it's severe, they always need someone's help or supervision when they're walking, or they're unable to self-propel a manual wheelchair. And very severe, these people are bedbound and they are not participating in their transfers. So social. So this is a huge thing as well that is often under-recognized in other sort of medical ways of thinking about things. The ability to have social support is well known to be an important determinant of health, but often is not considered in acute care. And so one of the things that this way of looking at frailty, it says it's really important to look at that person's context. So for number 1 or 2, so those people that are fit, thriving, these people are in charge of organizing social events. So that's, they can do Christmas dinner, no problem. They've got the list. They send out who's going to bring what. They do the whole thing. Normal aging, they socialize weekly, and if they needed to have a caregiver, one would be available. If they're vulnerable, they're socializing less than each week, and they may not have a caregiver available if it's needed. 5 or mild, they socialize rarely. Moderate, they're mostly housebound and might have a caregiver. Severe, they're housebound, isolated, there's caregiver stress, or there's no caregiver available. Very severe, they're unable to participate in any social exchange, even when visited. Okay, so moving on to function. So this is where our occupational therapists come in when we're looking at frailty. So, when they're thriving and well, they might still be working, or they're doing hobbies that they love and they're doing them really well. Normal aging, there might be some subjective impairment. They're doing everything on their own, but they might be finding it a little bit more challenging than previously. If they're vulnerable, they're not dependent, but their symptoms are limiting some of their activities. So mild, they need help with their IADLs. And moderate, they are dependent for their IADLs and they need cueing for basic activities of daily living. Severe, they need help with both of their IADLs. They're dependent for their IADLs and they need hands-on help with their basic activities of daily living. And for the terminal stage 8, they're dependent in every aspect. So one other thing that's often not recognized and is extremely important in looking at frailty is cognition and dementia. And so often in healthcare, dementia is the X factor. And certainly my mentors in geriatric medicine certainly have taught me about how important it is to look at this, and also how often it's not recognized. So dementia is quite common and unfortunately incurable at this time. So it can be missed up to 75% of the time, which is just amazing. And the thing is, people who are not in geriatrics, unless someone is really impaired, very obviously impaired, then they're not seen to have dementia most of the time in healthcare. And the thing is, it does predict adverse outcomes. If they have a dementia, even a mild one, if they get a delirium, they may never fully recover. And if they do get a delirium, the likelihood of having worsening of their functional status or needing to go to long-term care increases. And when we do interventions like that gentleman with the AAA, we can actually worsen their quality of life. So it's this paradox, right? We're trying to do the right thing medically, but in fact, it's not working. It's fixing the thing that we think is the problem, but it's causing a cascade of very adverse events. And the other thing with dementia is it changes who and how the decision-making and care planning is done. So it's much more difficult to actually plan or consider different treatment options if someone has even mild dementia or mild cognitive impairment. So when we're looking at cognition, for the people that are well, obviously they're doing great. They're impressing people with how they think and their memory. In normal aging, there are maybe some mild changes, but the person is, as we said, functioning okay. Vulnerable, when we do see them having some deficits on our testing. So maybe their MoCA is 24 out of 30, those kinds of things. Mild, they have an incorrect recall of current events, but they can name the US president. So this is done based on Canadian data, so this isn't an American slide. So Canadians often still can remember who the US president is, and actually it's kind of expected. So if they can't, then we would say they're in mild range. If it's moderate, they wouldn't be able to recall the name of the US president. They can, however, remember the name of their spouse and their children, and there may not be a collateral present. If it's severe, they have vague or incorrect recall of children or spouse, so you might have people mistaking their family members for other people. And very severe, they have very limited language and may have speaking less than 10 words. One of the things that I haven't highlighted yet, though, is that this assessment relies on collateral. So if you are doing this assessment without getting verification that this is actually true for all of the 4 areas, your assessment of frailty is inaccurate. I can't tell you how many times people have asked patients, so, are you having any trouble with taking your medications? Oh, no, doctor. Do you ever forget to take your medicines? Absolutely not. I'm very good about taking my medications. Or, have you ever fallen in the past year? No, I have not fallen in the past year. So, and it's not that people are lying. They are telling you to the best of their ability what they think has happened. But if you don't get collateral, you can often be mistaken. So one thing that, one of the reasons why I really have sort of thought that frailty was a useful thing is I read an article published by Laurie Mallory and Paige Morehouse. And it just resonated with me and what I was trying to do with my own patients. And you guys, many of you may already know, have seen them. They presented here in September. And they are 2 geriatricians that are from Halifax. And they have developed this model of care that's called palliative and therapeutic harmonization. So palliative being that we're recognizing that people that are frail are in the last chapter of life. So we really need to be thinking about that. And therapeutic, meaning that there may still be things that we should be offering. And we should be thinking, we shouldn't just say, oh, you're 85, so therefore we're not going to offer you whatever. We need to be looking at how well this person is in terms of their frailty or their degree of vulnerability. And their plan really is to have this 3-step process. So encounter 1, they get the health history. So they actually spend time with a structured interview getting the health history, ensuring that they get collateral information, and going through all of the things that we've already talked about in terms of mobility, function, cognition, and social. So they get a really good understanding of who that person is and where they are in their life. In the second encounter, they communicate information to the patient and to the loved ones of that patient. And they give them detailed information about their frailty and about where they are, their prognosis, and often that's a very challenging conversation because in many instances, no one has ever discussed that before. And in the third one, they empower the patient and the family and the loved ones to be able to make good decisions if they're facing a health crisis. So as you can imagine, many of these people are ending up in the emergency department, and they may be being offered surgery, they may be offered going to the intensive care unit, being admitted for medications, and if the family and the loved ones or the substitute decision maker have a clear understanding of the degree of frailty, they're going to be much more able to say, yes, I'm willing to undergo that risk, because they're going to understand what the risk is. And they're also going to know what are the goals of that person who's sick in the emergency department. So they've done a little bit of work looking at this, and they have this study that was done in JAGS in 2012, and it looked at where some of the referrals have come from. And certainly a lot of them, because their program was initially in acute care hospitals, so a lot of them came from specialists. But there were primary care, geriatricians even referred to this program, emergency department as well. And looking at the outcomes, so here they have 71 patients who came into the PATH program, and those 71 patients had 77 procedures that were already scheduled. So clearly some people had more than one. And so they went through this process to learn about their health situation, what their prognosis was, and what the risks were of many adverse events that faced frail older people. At that time, many of them decided then not to go on with the procedure. So 75% of those 71 people decided not to proceed with those procedures because they felt that the risk was too great and that they were risking a quality of life that they did not want to lose. Some people did go on, and a few were unsure. So the other thing is that by doing this, by communicating, for learning the story, communicating the prognosis, and talking about what the risks and benefits are, you actually get very high patient and caregiver satisfaction. The qualitative research that they've done on this is people say this is something that's not available anywhere else. People start feeling much more confident in their ability to make decisions in a crisis. And they also discover that there's options beyond aggressive medical interventions. So, I do know of a patient recently that was being considered for, was being referred for a transaortic valve replacement. And he had significant dyspnea. And the person who was looking at him said, I think this person is quite frail. Are there other options? And when they actually talked to the substitute decision maker, they were like, yeah, we don't want to go on with this. We don't want to undergo a procedure. We really just want his symptoms to be better. Is there nothing else that we can do? They were okay with the fact that the person was not going to have a lot of time left to live, but they just wanted some comfort. They also know that there's someone that they can call if they're having difficulty making a decision. So far, frailty shows predictive validity. It is feasible to measure it. And once it's recognized, it actually gives us opportunities to do planning. So it's one model, and it looks like it helps with making better decisions, that it has high satisfaction, and that it probably provides better and less costly care. So we're hoping to bring this to Ottawa, and we're hoping to move from frustration to a much more satisfying interaction. So you have a big role to play in assessing, managing, preventing, and educating, and overall in caring for these patients. Thank you. Any questions?